but good morning, everybody. It is my pleasure to introduce Chris Longhurst, who is the Chief Clinical and Innovation Officer at UC San Diego, where he oversees the offices of the Chief Medical Office, Patient Safety and Quality Improvement, Care Management, and the Jacob Center for Health Innovation, among his many other roles. But as you've heard, many of us know him as a friend, a mentor, and an instigator in every sense of the word. When he was here more than a decade ago, he did many things, including starting our first operational clinical informatics team. He was appointed as our first chief medical information officer, and he helped lead our huge Epic implementation, which Lisa Grissom remembers very well. I think she helped find him and pull him into IS, if I remember correctly. But just doing a huge implementation wasn't enough for Chris. He gets bored easily. So at the same time, he realized that clinical informatics was becoming a specialty that could transform care, and that it was becoming a board certified specialty. And that meant there was going to be an opportunity to start a fellowship to train the next generation of healthcare leaders. So in November of 2013, he convinced a half dozen of us to sit for the first clinical informatics boards, which meant that in January, we became the first class of board certified clinical informaticists, so that in April, we could submit a huge application to start a clinical informatics fellowship a mere month before our huge Epic go live in May, so that we could start our first fellows in July. Little bit of a crazy time. That wasn't enough, because at the same time, he had us using evidence-based implementation practices for this huge project and studying the outcomes so that we could then publish in peer-reviewed journals as a byproduct of our operational work. When he initially proposed all these ideas, we thought he was insane, which he is. But Chris has this incredible ability. He is a true visionary. He pushes boundaries, not just for individuals, but for medicine itself. He has the ability to inspire people, systems, and even data itself to be better, to do more, to transform care in ways that we hadn't imagined. So I encourage you today, as you listen to his talk on evidence-based pediatrics in the very exciting AI era, to listen to how he not only innovates, but elevates. He has this gift to see a future that is exciting, achievable, and one that is already unfolding. Please help me introduce Dr. Chris Longhurst.
All right, that was an amazing introduction. Thank you, Dr. Pagler. Thank you to Dr. Mary Leonard for having me here. For all of you coming and for all of you on Zoom, because there are no empty seats in the auditorium today. So we're happy that you're at home, Dr. Stevens. It's really a privilege to be back here after 10 years. And I'll tell you, the overwhelming sense I get is of gratitude, just seeing so many friends and colleagues, people who trained me. One of the roles that Dr. Pagler did not mention is I am still seeing patients. And my very first pediatric attending, Dr. Fernando Mendoza, came out of retirement to join us here today. So thanks, Fernando. Now, I don't have any conflicts relevant to the presentation today, but my mentor, Dr. Atul Butte, was fond of saying that you couldn't scale what you were doing in academics without partnering with industry. So I have lots of conflicts and I'm looking for more all the time. So you shouldn't believe anything else I say. But I did want to start with a little bit of a trip down memory lane. So Dr. Schroeder, you've aged very well. Alan looks barely different than he did here 19, 20 years ago. But somebody who has changed quite a bit is Zoe Grissom. And you see Zoe there when she was about 6 years old. I think she's like 23 now and out of college. But this was what it was like when I arrived here in July of 2001 as an intern to start learning how to practice pediatrics. And you can see that Dr. Palma is writing on a piece of paper, and some of you in the room remember paper that looked like this. In fact, they were all triplicate forms and they were pre-printed as Packard Children's. And June 23rd of 2001, when I was going through orientation, I remember Bob Poole and Fred Nishioka, who came down to intern orientation to take us through the Hall of Shame. And the Hall of Shame was a series of overheads that went on an overhead projector. Now, this is only 20 years ago. And they would show us all these bad orders that interns and residents had written. And they said, well, make sure you don't do this and make sure you don't do that. So what's wrong with this order? Anybody who remembers paper orders? So nobody remembers paper orders. It's clearly in the NICU bill because it's to rule out a PDA. We've got lots of unapproved abbreviations there, like morphine, or is that magnesium? But one of the biggest issues was that there was no leading zero before the decimal point. And this actually resulted in a 10-fold overdose to a preemie who was getting that echo to rule out PDA, who then had to be put back on the ventilator because that baby stopped breathing. So this was the kind of thing we were looking to do when we, looking to prevent when we started the Cerner implementation many years ago. And I want to credit Dr. Paul Sherrick, who I think was 2 chief quality officers before Dr. Grace Lee here. Paul served in that role for 20 years, and he was fond of telling the story about the Quality and Safety Subcommittee of the board at Packard Children's, which heard about stories like this and asked what they could do. And this is right around the time the Institute of Medicine report To Err is Human came out, which of course suggested that a 747 worth of Americans die every day, or about 100,000 Americans on a yearly basis because of medical errors. And the follow-up report came out while I was an intern, Crossing the Quality Chasm. It suggested that electronic orders and health technology was one of the key ways we were going to prevent those type of medical errors. And so the board at Packard Children's wrote a check and said, please start doing electronic orders to help prevent this. And so we started that project. And because of Dr. Lisa Chamberlain, I joined Lisa Grissom and the team, and it was really exciting to be part of this big project fresh out of residency. And then a bomb dropped in December of 2005. Now, this is one of the top 5 most cited articles in the journal Pediatrics for the entire decade, okay? And it's known as the famous Children's Pittsburgh article, because what it showed was that a Cerner implementation at Children's Pittsburgh was associated with an increase in mortality. In fact, this article made the rounds like wildfire through our adult colleagues and the entire country. And we gave it a lot of thought. In fact, we had an entire hospital administration meeting that our CEO, Chris Dawes, attended to talk about this paper and what we thought about it. And we put our heads together, and Dr. Jen Hahn, who was the hospital's first CMIO, and Jill Sullivan and Paul and myself wrote this letter back to Pediatrics where we said, you know, we think that it was inadequate preparation and policy changes, like they wouldn't allow patients being transported in to get orders prior to arriving physically. That's what contributed to this. And in fact, turns out the Pittsburgh folks did cherry pick their data, because as soon as they changed that, the mortality had gone back to previous levels. So we said, you know, we're moving forward. We're going to continue this crazy electronic orders project, and we have confidence in that. And shortly after that, Seattle Children's, Mark Del Beccaro, who then became the chief medical officer, and hired away Dr. Paul Sherrick as the chief quality officer at Seattle Kids. Mark published this paper. He tells a story about staying up all night on vacation with his wife in Hawaii to write it in the bathroom, because he felt so passionately that Pittsburgh folks had come out and helped Seattle. There was this whole network of children's hospitals that were working on electronic orders. And he said, you know, at Seattle Kids, because of what we learned from Pittsburgh, we didn't have any change in mortality. But of course, that's not what you're looking for, right? And so it was with great pride in 2010 that we published this article that showed that we actually had seen a decrease in mortality in our hospital. Now, this was a pre-post. It wasn't a randomized study. It wasn't conclusive. It wasn't because our electronic orders or health record had caused this for sure, but we had some hypotheses. Before I share the hypotheses, though, I do want to point out that our chief of staff at the time, Dr. Christy Sandborg, who was a key advocate for this program, was a co-author, as was Christopher Dawes, who I know passed away a few years ago, and we all remember him fondly. So why might this have happened? Well, we saw a 20% decrease in mortality, which translated to 36 children's lives over an 18-month period. And it wasn't because of medication safety orders. That's not why we saw the change. Did we see a decrease in errors? We did. But did we see a decrease in medication harm? Well, it turns out medication harm is both a small percentage of medication errors and a rare cause of death in children, right? What we did see, though, is when you no longer had to fax or tube those triplicates to Bob in the pharmacy, we saw an improvement in medication turnaround times. We saw an improvement in lab turnaround times, an improvement in radiology turnaround times. Care got more efficient and faster. And that's our hypothesis for why that might have made an impact. In fact, there were several follow-up studies, and this was cited in the Institute of Medicine report on health IT and patient safety. So that's a little bit of background. And that leads us up to the next decade. And of course, during that time, we then decided to pull the plug on Cerner, put in Epic. We did all of our physician training over in the football stadium. Dr. Julie Pantaloni and Dr. Lindsay Stevens wrote some wonderful papers about how we had the best training outcomes Epic had ever seen. I think it was a football stadium bill, which generated a lot of excitement. But we moved on. And one of the things that we moved on was feeding all of this data to the Stanford Translational Research Integrated Data Environment, or STRIDE. And that resulted in this next story. So Dr. Scott Sutherland is in clinic in Sunnyvale today, so hello to the nephrology team. But Dr. Jenny Frankovich, I think, is here. And Jenny was one of my colleagues in residency and became one of our star pediatric rheumatologists. And Jenny admitted this child with known lupus who'd been followed here at Packard, but was flown in by life flight in extremis. So she had end organ damage as evidenced by hepatitis and nephrotic range proteinuria. And she was really sick. And as Jenny was at her bedside in the pediatric ICU, she asked a really smart question, which is, she's losing so much protein in her urine, she might be hypercoagulable. Should we anticoagulate her? And the bedside team did what any good evidence-based doctors would do. Alan, they looked up the literature, and how many studies were there about teenagers with lupus and clotting? None, right? So they do what good evidence-based clinicians do next. They ask for expert opinions. And at the time, with Dr. Steve Alexander leading the division, we had 5 pediatric nephrologists. I think Dr. Sutherland was still a fellow. And we asked the first pediatric nephrologist, who said, oh, absolutely. We had this patient recently who clotted, really, bad outcome. You should anticoagulate. But then we saw another one, and we asked that nephrologist, what do you think? And that nephrologist told us what? Absolutely not. I had this patient once, anticoagulated, horrible outcome. And so Jenny was left holding the bag, and that's when she did something that hadn't been shared in the literature before, which is that she went back to STRIDE, where we were feeding all of that Cerner data, and she asked the question, what happens at Packard to children with lupus who are admitted to the ICU in extremis like this one? And on the day that this girl was admitted, Jenny found a cohort of 98 similar patients over the previous 5 years, and she divided them into similar and different based off lab findings. And then she looked for outcomes based off of keywords like thrombosis and clot. And on the day that this girl was admitted, she found a 12 to 15-fold increased odds ratio of clot in patients like this one. And based off of that, the team made the decision to anticoagulate. And I said, Jenny, that's an amazing story. We got to rate it up. She said, yeah, I got to put it in a rheumatology journal. And I said, no, Dr. Butte, my division chief, just taught me about these viewpoint perspective pieces. We got to tell the story. And she goes, if you think so, Chris. And Scott, Jenny, and I wrote this up. And it's become one of our most cited articles because it helps to create that vision of the future of what should be possible with all the data that we're putting in electronic health records, particularly in an organization like Packard Children's, which is seeing so many children who are N of 1, who have such atypical and unusual presentations or diseases, where other children like them may be spread out across the country or the world, right? Now, this generated so much interest that it was actually also cited in an Institute of Medicine report that came out in 2013 about learning health systems. There was a whole call out to the Frankovich et al. Paper, which talked about how real-time data or real-world evidence should be used in the absence of peer-reviewed papers to help guide treatment decisions. Wouldn't that be terrific? Right? This is only a decade ago or so. We're not quite there yet, but we're on the way because we want to make sure that all of the data that we're generating, all of the evidence that we're potentially generating, even if it's not being used to write up clinical research papers by eager fellows, is still contributing to better outcomes for patients. In fact, one of the things Dr. Phil Pizzo taught me in his 10 years as dean here is that probably one of the most evidence-based specialties outside of adult cardiology is pediatric oncology, right? And over the course of 25 years, pediatric oncology cure rates for acute leukemia shot from less than 20% to over 85% with no new medications, no biologics. Why? Because every child in the country, about 3,500 on an annual basis that get cancer, are on trials, right? And Dr. Paul Fisher is making sure that we're learning from all of their experiences every single time. And so we got a lot of questions about, well, how would you systematize this? And so I met with my colleague Nigam Shah, who of course is still here, works closely with Dr. Topher Sharp in the adult hospital, and Bob Harrington, who at the time was the chair of medicine, now is at Cornell as the dean. And we envisioned this future of a green button where you could click a button inside your Epic EHR that would give you some of these answers that would help you understand what similar patients had experienced. And what we described in this is, importantly, you would only use this button in the absence of relevant peer-reviewed evidence, right? If you have a 65-year-old white male with hypertension, it's very clear what the first-line antihypertensive should be because all the clinical research has been on patients in the VA like that patient, right? But if you have a 45-year-old half Vietnamese female with comorbid asthma, it's not so clear what the first-line antihypertensive would be. Wouldn't it be great if you could click a button, see what the entire Stanford experience over the last decade, or the Kaiser experience, or the country's experience had been? And of course, you need to use your clinical judgment with that practice-based evidence. And one of the outcomes would be your clinical decision, but another outcome would be a prioritized list of situations for which comparative effectiveness data is needed. And that's a really important piece because ultimately, to conclusively answer these questions, you need point-of-care randomization. Did we make the right decision for that child with lupus? Well, the answer is we don't really know. We know that she didn't have any sequelae from the anticoagulation, and she didn't have a clot. But at the end of the day, it was an N of 1. It wasn't a clinical study, right? We still don't know how to treat these patients conclusively, but this point of care randomization is what would allow us to do that. So after I left and went down to UC San Diego about 10 years ago, Nigam and Bob and the team continued working on this. They published some of their outcomes for the Clinical Informatics Consult program at the Stanford Adult Institution. Nigam spun off a company for which I have no interest, and I'm a little bit bitter. And ultimately, our vendor, Epic, has released something called Cosmos. And both Stanford Adult and Children's now participate in Cosmos. University of California has just recently signed this as well. I know Dr. Schroeder has been involved with conversations with Epic about this. Dr. Matt Eisenberg, who was a co-author on that earlier Seattle Children's paper, has also been working on this. And there's a lot of opportunity here. So that clinical research piece, I don't want to lose. How do we do randomization at the point of care with electronic health record? Well, we did our first one at the University of California just a couple of years ago because we wanted to understand how neutralizing antibodies help protect against COVID. And so we started a study where all you had to do as an employee or student was scan this QR code and you were going to self-schedule with Epic. And then you were going to consent to treatment with Epic. And then you were going to get your research results, not your CLIA-approved lab results, inside of Epic. We did a fully EHR embedded trial. And over the course of 4 weeks with no funding, we accrued over 2,000 research participants because it was fully EHR integrated, right? And this is part of the future. And so I'm very grateful to our fellow, Dr. Nicole Goldhaber, who's actually a surgical resident as well as clinical informatics fellow, and wrote this up. And you can read more about that effort. But I do want to take a second to pause and hit on something Dr. Pagler mentioned, which is as we think about the future of healthcare delivery and healthcare discovery, like clinical research, these fellows are going to be part of that future. And so it was really outstanding to be part of the team that founded the fellowship program here. And I'm so grateful that our first graduate, Dr. Vina Jones, at the time, Dr. Vina Goel, has joined us. And you see that team, including Dr. Topher Sharp, pictured here, not only mentioned that we were actually the first in the country to be accredited, but I have to acknowledge that we wrote this paper up so we could memorialize that, but it was really a fond coincidence because of the 4 first fellowship programs, we happened to be sponsored by Pediatrics, which did their RRC review before pathology, internal medicine, and what's the other one? Emergency medicine. And I will tell you to this day, the program directors at the other 3 institutions are kind of pissed that our Stanford PR machine really took this to heart and said, we're the first in the country. But thank you, Vina, and thanks to all the fellows. And Dr. Keith Morse is here. Keith, raise your hand. Keith is the current fellowship director and a graduate of the program and continues this outstanding legacy. All right, so we started this journey talking about quality and patient safety. And so let's go back that a little bit and talk about this report, which came out now over 20 years ago, right? In fact, 1999, 25 years ago to Error is Human. National Academy of Medicine just celebrated the 25th year anniversary. So how are we doing now 25 years later? Have we decreased harm everywhere? Well, turns out no. And Grace, for people who've been working in quality and safety for a long time, like myself and Paul and you, this is a tough pill to swallow, but we've got to acknowledge it, right? So Dr. David Bates and some folks in Boston did a bunch of study in the 90s that culminated in that IOM report. And Dr. Bates then did another study just last year that showed that 25% of hospitalizations in Boston, which, Grace, they tell us is like a good set of hospitals, but we're not sure whether to believe them. 25% of discharges from the hospital had adverse events, and at least a quarter of those were preventable. So have we made progress? We're not really sure. We're not really sure. In fact, what about pediatrics? Well, Dr. Paul Sherrick, who's still publishing up at Seattle Children's, helped me answer this question. I said, Paul, is there evidence that harm has improved in pediatrics? Because you got solutions for patient safety and children's hospitals working together, really at an unprecedented level, much more deeply than some of our adult colleagues who like to compete. And the answer, Paul said, was no. It hasn't. There's really not good evidence. And in fact, I asked folks at the National Academy, the CDC, and a number of other organizations. And the general consensus is we've made some progress in healthcare-associated infections, like central line-associated bloodstream infections and catheter-associated UTIs. We've definitely made progress. But when it comes to other areas of medical errors and harm, the answer is no. And in fact, one of the largest areas of medical errors is the hardest to study. And we get that data from our colleagues in the legal profession. The number one source of malpractice lawsuits, the number one source of malpractice settlements, and the number one source of the largest malpractice settlements is delayed and misdiagnosed patients. In fact, in a room this size, let me just ask you, how many of you know a friend or family member or loved one that had a delayed or misdiagnosis? So about 50% of this packed room, for the Zoom folks, raise their hands. And the data show that by end of life, every single individual will experience this, right? And that's really part of our opportunity, right? Is to use data on patients like us to help reduce that. And so we're going to talk a little bit about how AI can help. But first, I want to share personal experience with medical errors that occurred when I made the mistake after the Epic Go Live of shooting down Woodside Road with Dr. Pagler on a bicycle, and then spent a week in Stanford Hospital recovering from 2 broken arms. Now, interestingly, I was on the trauma orthopedic service in the old hospital in the basement, and the trauma ortho service had a protocol for DVT prophylaxis that said, if you have any lower extremity injuries, then you should be prophylaxed for DVT. But I had 2 broken arms. I went to the OR twice over the course of 3 days. I was narked up and was not walking. But the protocol, the order set, didn't lead me to getting DVT prophylaxis, right? And so a week later, when I started getting knee pain, like any good pediatrician, I thought they'd missed an injury on my knee. But our other fellow, Dr. Lance Downing, who was an internal medicine graduate, said, Chris, I think you probably have a blood clot. Let's take you back to the emergency department, where I was diagnosed with a DVT. Now, Dr. Rusty Hoffman, who for 20 years led interventional radiology, pioneered a procedure called venous thromboembolectomy, where they actually took that blood clot out. So I was super lucky because I don't have long-term sequelae from that blood clot. But I'll tell you what I did have is another hospitalization, another procedure. I was anticoagulated on Xarelto for a year, tens of thousands of dollars of medical expenses from a medical error that was preventable, right? So let's think a little bit about how AI might be able to prevent that type of stuff. In fact, I got together with Dr. David Klassen, who was the recipient of a Robert Wood Johnson grant and Gordon Moore Foundation grant on patient safety to think about how AI could make a difference. And so we put together this draft of at least a dozen different places where AI has already been shown to improve patient safety. So I want to share some of our more recent experiences at UC San Diego with a couple of these, and then we can wax philosophic about the future. So one of these is simply chest x-rays. Turns out UC San Diego does about 120,000 chest x-rays per year. The emergency department accounts for the large bulk of those. They really like chest x-rays in the ED, but of course our ICU and outpatient elsewhere as well. And the pandemic hit in San Diego about a month before it hit most of the country. And that was because we got a call February 6th from the county of San Diego who said, the military is evacuating expatriates from Wuhan. The plane will be landing at the Miramar Corps Air Service, which of course you know as Top Gun. And if we have any patients testing positive for this new SARS, can we hospitalize them at UC San Diego? And without hesitation, my CEO said, absolutely, we're the county hospital, that's why we exist. So we got our first patient on February 8th. And I remember as we launched all of our processes and policies and 10,000 man hours of work went into preparing for this. I was thinking, gosh, is this going to be another SARS kind of episode, and this is all for naught? And it wasn't. And so in fact, a month later, when the White House and the World Health Organization declared this pandemic, we had already built in a lot of order sets and things like that. And one of the things that we were doing during that declaration on Friday, March 13th, I was sitting in a conference room with Dr. Albert Shao, one of our radiologists who trained here at Stanford Adult. And Albert's one of our imaging AI experts, and he had already had a paper accepted about identifying COVID pneumonia using a set of Wuhan chest films. And because it had already gone through peer review and been accepted, even though it wasn't published, we felt comfortable moving it in production. And so a project that normally would have taken 10 months took 2 weeks because we had all the right people focused on this. We got this live on April 1st. And I remember walking through the emergency department on April 3rd. And I asked one of the ED attendings, have you seen this color on the chest x-rays? Is it helping you at all? And she said, yeah, actually just 2 days ago, we had a patient come in from a nursing facility. She was being evaluated for enlarged heart. So we got a chest film for possible heart failure. And even though the radiologist didn't call any pneumonia, there was some color on the x-ray, so we got a COVID test. And I said, well, what did it show? And the ED attending said, well, we only get a few of these. It takes 48 hours. And I'm like, oh, we got to see it. So I looked over her shoulder as we looked it up, and sure enough, it was positive. And this patient was followed closely by our outpatient SARS team, as well as by me. She was actually proactively hospitalized about 3 days later as she started to develop respiratory symptoms. She was cared for at our ward level of care, didn't require going to the ICU, and she went home. And to me, this was an anecdotal success, right? This was a case where AI found community COVID, one of the first in San Diego, that wouldn't have otherwise been diagnosed, right? But anecdata is not peer-reviewed data. And so I said, well, we got to figure out if this is actually making a difference. And so we did a study in the emergency department over the course of the summer of 2020, because the ED is where we found this was making the biggest impact, not the ICU, not outpatient. And so Christian Demeth was one of our clinical informatics fellows and led this. He was an ED attending. And we found that over the course of the summer, there were 5,000 visits, 2,000 chest films, and the physicians who were surveyed, both residents and attending, found it was easy to use. The colors showed up in the packs. But 1 in 5 cases, this resulted in a different clinical decision. And for anybody who's done best practice alerts in Epic and things like that, changing clinical practice at that level is really unprecedented. So I thought this was a huge success. But of course, it's survey data, right? It wasn't super conclusive, but it was the best we could do. We got it published quickly. And in fact, one of our outcomes on this was that because we were monitoring carefully, we saw that there was an extinguishing effect. And by the end of 2020, it was no longer useful. And so we actually turned off this whole AI. Why? Because people were using it to help decide whether to test. And by the late fall, everybody who stepped foot in our waiting room was getting a screening test for COVID, right? And so the president outlined this in the blueprint for AI, that AI needs to be monitored on an ongoing basis for adverse outcomes rather than a single offsite evaluation. And that's really key, that we're monitoring these things after we put them into practice, particularly with adaptive decision support that's going to change as the data inside the system changes, both data about patients and sometimes data about these algorithms. But there was another learning here that I really want to stress, which is that a couple years later, my narcissistic Google Scholars alert found a citation to this paper. And I eagerly looked up the paper citing it because it was a review article of all AI papers during a 2-year period of COVID. And This review article found that there were 9,000 studies in PubMed about COVID that mentioned artificial intelligence over 2021 and 2022. And of those 9,000 articles, they searched through using a threshold that was very low for clinical outcomes. And how many of these 9,000 articles had clinical outcomes described? 4. 4 studies had clinical outcomes. So I actually downloaded this PDF. I didn't just read the abstract. I was like, well, which were the 4? And one of those 4, in fact, one of the 2 from the US, was that study I just showed you, which was not God's gift to studies. This was a survey-based study, right? So something's wrong because we're rushing to publish about AI algorithms, but we're not publishing about AI outcomes, right? That's what matters, right? It's about the patients that we're caring for and the outcomes that we're trying to achieve. And so we have to understand these algorithms and what they have the potential to do, but there's so much more that goes into the outcomes. And in fact, another review study of AI in critical care, including pediatric critical care, shows the same thing, right? Look at all the studies coming out about models and look at the paucity of studies about actual clinical outcome evaluation. So let me use another example where this is highly relevant. And that, of course, is sepsis prediction. So I don't need to tell this audience that sepsis is an incredible killer. In fact, 18 children die every day of sepsis. Across the US, 1.7 million adults are diagnosed with sepsis, and about 350,000 adults die on an annual basis. This data holds true in San Diego, by the way. Our county is about 3 million people. It's about 1% of the population in the US. And indeed, we see about 17,000 adults diagnosed with sepsis and about 3,500 dying in San Diego County on an annual basis. And so as I became the chief medical officer for the hospital and was looking at our sepsis outcomes, I saw that we could do better. And I appointed Dr. Gabe Wardy to be the medical director of sepsis care. He is boarded in both critical care and emergency medicine, outstanding choice for this role and doing a great job. Really pushing the boundaries on how do we achieve known best practices, right? Be highly reliable by implementing the sepsis bundle and SIRS criteria and all the stuff that we're supposed to be doing like every other hospital. But then I also paired him up with one of our data scientists, Dr. Shamim Namadi. Now, we recruited Shamim from Emory University, and Shamim already had $6 million in BARDA grants to study sepsis AI. And I asked Shamim, why are you interested in leaving like Emory and coming to UC San Diego? And he says, Chris, I published all these papers and gotten all these grants, and it's never been implemented once. And I said, well, come to UC San Diego because I'm really interested in seeing how we can push the boundaries and improve our outcomes, right? And so Shamim and Gabe paired up together. In fact, they became such good buddies that they had their first kid at the same time, their second kid at the same time, their spouses are friends. And after about 6 months, I said, Shamim, we're building the pipes to implement your AI. How's it going? And Shamim says, Chris, it's fantastic. I've learned so much more in the last 6 months than the previous 6 years. I said, what do you mean? He says, well, Gabe has me sitting on the hospital sepsis committee. I said, yeah. And he says, well, now I'm starting to understand that it's not just the algorithm because we can't just alert the doctor all the time. They may not be on the computer, or they might not be caring for the patient. It could be hours before they see the alert and log in the EHR. So yeah, what are you gonna do? He says, well, we're looking at the bedside nurses, but if we alert the bedside nurses, they don't have the scope of practice to be able to order the missing labs and some of these other. So that's right. So what are we gonna do? He says, we're partnering with our lean process improvement team, Dr. Platchik, and we're looking at redesigning workflows. And we're gonna take our centralized code team and we're gonna make them responsible for some of these centralized sepsis alerts so that they can, under scope of practice, we got nurse practitioners and others, order some of these missing labs. I said, that's great. And so this team has just done incredible work. One of the things that they did, it hadn't been described before, is they actually taught their algorithm how to say, I don't know. So that in cases of low confidence, rather than making what appears to be a confident prediction, the algorithm would say, I don't know if this patient has sepsis. And that increased trust among clinicians in the algorithm, and they published papers on that. And then in January of last year, Dr. Bassina, one of our postdocs, published this paper with Shamim and Gabe, showing that the implementation of this algorithm over a 2-year period had been associated with a 17% relative decrease in mortality for sepsis in our emergency department. And importantly, a plausible reason for that, which was a 10% relative increase in sepsis bundle compliance. And you can see the EPIC BPA in this paper, but the AI all occurs kind of outside of EPIC, and we were really thrilled with these results. In fact, we had at the time 2 emergency departments, now 3, And they serve very different patient populations, Dr. Chamberlain. In La Jolla, we see a lot of our cancer patients. And it turns out that our clinicians in La Jolla were really good at identifying sepsis in patients with cancer who have an average age of 63 to 68. But in our other emergency department down in Hillcrest, we see patients that may have sepsis for other reasons. In fact, the average age of sepsis patients there is in their 40s and 50s, and they have underlying immunocompromise from other reasons like HIV. And we don't do as well in that area. And so we tuned our algorithm to actually help us close that gap in health disparities. And we have a paper coming out about this that shows that, and you'll see the data in this paper, that we actually had a 24% improvement in sepsis mortality in Hillcrest and a 12% improvement in La Jolla that accounted for the 17% overall relative decrease. And that's a story about how AI can be used to help close health disparities as well. Now, I really like this paper, and even though I didn't write it, I'm citing it because the editor of the journal that we published in really put it eloquently when he said, it's time for AI researchers to shift the focus from algorithm metrics such as accuracy to meaningful outcomes. And you can see this entire editorial that Dr. Kvetter and the team wrote from Boston is about the UC San Diego paper, and they describe some of the best practices that they thought that we had described in our article. And they say, funding agencies and journals alike should be encouraged to prioritize such studies. And I can't emphasize this strongly enough. I know Dr. Pagler and the team here are really focused on the same thing. Something that I learned from my mentor, Dr. Paul Sherrick, is let's focus on what matters. We've got to learn these algorithms, but we have to figure out how they're making a difference in care. That's where I think we need to head. And so it was with this vision that we founded the Jacobs Center for Health Innovation. Our mission is innovation at scale with impact, and we're incredibly grateful to Erwin and Joan Jacobs for the generous gift that makes this possible and allows us to do things outside the hospital margin. And Stanford Adult and Stanford Children's have similar wonderful resources, and really excited that you guys are leading in this space as well. So I want to share one last set of stories. Before I do, though, I want to just briefly mention that the flip side of AI is cybersecurity, because your AI strategy is your data strategy. And we have to treat this protected health information like the gold that it is. It's our patients' data. And so one of the things we also founded was a Center for Healthcare Cybersecurity. And this was based partly on some work Dr. Demeff did after some hospitals in our area got ransom. 5 of the 13 hospitals in San Diego County went down. They were on bypass for trauma, on bypass for STEMI, on bypass for stroke. And during that time, we actually found that our ED volumes increased to unprecedented levels. And in fact, our CEO, Patty Mason, was a co-author on this because we had to pull all sorts of strings to deal with this unprecedented rush in patients who were either being diverted from those 5 hospitals or were choosing to come in from home and didn't want to go to the hospital that only had paper records. How much time has changed, right? And in fact, we then published another article looking at out-of-hospital cardiac arrest mortality. And during a 3-week period that those hospitals were down, we saw an increase in out-of-hospital mortality. Very similar to a famous study published out of Boston about the marathon. Turns out when the Boston Marathon's in town, cardiac arrest mortality goes up. Why? It's not because of the runners. Anyone? Traffic, right? You can't get to the hospital. And the New England Journal study on the Boston Marathon showed that door-to-balloon times had gone up. We don't have that process data to be able to show it, but it's certainly plausible that with 5 hospitals on bypass, it took longer to get to the hospital, right? And so we founded this Center for Healthcare Cybersecurity, and we actually got a large ARPA-H award. And I want to tease you with this tidbit, which is hospitals like Lurie Children's that have also experienced ransomware. We have now set up an early detection network. Every hospital that has been publicly announced as a ransomware victim in the last 10 months, we have detected at least 12 hours before it was public information. All right, back to the AI. So I am fortunate to still work with some really smart people, and Dr. John Ayers called me in December of 2022. And John said, Chris, you played with this ChatGPT thing. I said, yeah, I'm playing with it right now. It's crazy, right? And he goes, yeah, you know what I'm doing, Chris, is I'm feeding it patient questions. And I'm like, John, you don't have access to my chart data. Where'd you get this patient questions? And he goes, Chris, don't worry about it, man. I just pulled them off Reddit. And he's like, there's all these forums where patients ask questions and doctors answer them on Reddit. I'm like, oh, that sounds great. And I said, well, what's it showing? He goes, Chris, you wouldn't believe the response. He started reading them to me and forwarding them on email. And I'm like, holy mackerel. So you might have heard some of the press that came out of it. John's really good at press. And some of the clickbait headlines said things like, chatbots are higher quality and more empathetic than doctors. And that wasn't my takeaway at all, right? My takeaway was that in a limited amount of time, physicians answering these questions wrote 4 sentences, and the chatbot wrote 4 paragraphs. And so I called up Sumit and Dr. Jackie Goldstein and others at Epic and said, hey, I've got an idea. I think something we could implement here. Are you working on ChatGPT integration? They said, yeah, in fact, we're right in the middle of it. And I said, well, we're all experiencing this, in-basket overload, particularly with virtual care in the pandemic. Maybe we can use AI to help respond. And so Stanford Adult, Dr. Sharp and Eisenberg and the team, and UC San Diego became the first 2 in the country to deploy this. And we did 2 things, I think, as we were co-designing this, right? One of them was that we kept a human in the loop. So aligned with our AI principles, we said, we're not going to allow a doctor to just send it, right? So there's 2 buttons, start with draft or start blank reply. There's no button that says just send. So that human in the loop principle gets operationalized through that. And the second thing UC San Diego did is our AI governance committee said, one of our principles is transparency. And we usually think about that as transparency of the algorithms. But what about transparency with the patients that we're serving? Should we be transparent? And we had a lot of conversation. I will tell you, I came out on the wrong side of this. I said, we use dot phrases today. We don't have a disclosure that says your doctor used a dot phrase, dot normal labs. But some of our patient and family representatives said, AI is different, right? AI is scary. And if you want to maximize trust with your patients, you should maximize transparency. And we made that decision. And I think it was the right decision. In fact, there's a New York Times article back in November that highlighted now with 400 health systems using this and tens of thousands of doctors, hundreds of thousands of messages, that some institutions have decided to disclose this to patients and others have not. I don't know what the right way to do this is because we're starting to use AI in lots of other areas. There's probably ways we could integrate this into the CODA, the consent to treatment, other things. But it was clear that this journalist had a bit of a chip on her shoulder about the transparency issue. And in fact, Assembly member Lisa Calderon got wind of what we had done, wrote a bill that we endorsed at the University of California. I testified in the California Senate. This passed was one of the 6 AI bills that Governor Newsom signed into law, went into effect January 1st. And it was inspired in part by this work. And it says, when using AI to communicate with patients, you have to disclose it. Interestingly, it exempts if there was human review, right? But if there's an AI chatbot calling patients, et cetera, it needs to disclose that. So what did we find with our in-basket outcomes? Well, I thought it was going to save us time. And again, I was wrong. The data showed it didn't. Turns out before AI, that it took about 30 seconds to read a short patient message and then write a short response. And after AI, it took about 30 seconds to read a short patient message and then read a long chatbot generated draft response, maybe edit it a little bit if there's something inaccurate or you want to change the tone, and hit send. But in our study, we found that this decreased cognitive burden. Dr. Sharp, Dr. Patty Garcia, and others on the adult side actually measured burnout and found that it decreased physician burnout. So even though it wasn't a time saver, we've continued to scale this. And in fact, our colleague, Dr. C.T. Lin at University of Colorado, recently published some great data showing that it's probably nursing staff who get the most benefit from this. And we're doing some of that same work locally as well. For example, in our OBGYN clinics, where almost all the messages are answered by the nursing staff and other mid-level providers, they think that this is wonderful, where the doctors have not found it great. So where are we going from this and how we do oversight? Well, this summer we published a couple of papers really trying to focus on that. We think health delivery organizations really have a critical role to play in this, not just kind of central assurance labs, but the sharp edge of care. I think I've shown you some reasons for that. And ultimately, I think that CMS needs to hold us as hospitals accountable for this. When Joint Commission comes, they should be auditing for AI governance on the front lines. And it's not often that you get a chief medical officer advocating for more regulatory oversight. But I think that this is the right way to do it. And finally, where are we? Oh, if you don't have time to read these articles, this is a nice AI-generated audio overview of these. It's 8 minutes long. It's 2 fake AI-generated voices talking about the papers, and it's kind of mind-blowing because one of the AI says to the other AI that it's like GPS in a cornfield. And let me tell you, there was neither a GPS nor cornfield in any of those papers. But it's fun. The X link tells you how to make it. So finally, what's next? Well, first of all, very exciting. The adult hospital is rolling out ambient AI documentation using DAX from Microsoft. And in breaking news, Dr. Pagler shared with me that the Children's Hospital has also signed DAX and is about to deploy ambient AI documentation. What are we learning from that? Well, our former student, Vinnie Liu from the Stanford Master's Program, and Brian Hoberman and others at Kaiser were actually one of the first to publish about this. I think it's really interesting. The most important part is it rehumanizes the exam room. The amount of time spent typing in clinic decreases dramatically. A great article featuring Dr. Sharp seeing a journalist as a patient describes this, making eye contact. And everybody remembers this famous 2012 JAMA perspective by a pediatrician who was actually a chief resident and whose patient drew this picture. And you see in the picture, the doctor's got her back to the patient. Now, some people have pointed out the patient's still smiling and the parents are in the room smiling, but this is not the kind of care we want to provide. And so liberating the doctor from their keyboard in clinic, I think, is incredibly important. But what about after hours reduction, pajama time? Well, the jury's still out a little bit on that. And in fact, some recent data from Advocate and elsewhere is also suggesting the time savings may not be there, right? And so I'll come back to this article I published in 2018 where we looked at note length across all Epic sites. And what we found was that sites in the US had a bell-shaped curve. I'll tell you, UC San Diego is right at the top there with the median note length of 3,800 characters. But international sites were much shorter, all less than 1,000 characters. In fact, the longest international notes were shorter than the shortest US notes. And let me tell you that some of these short US notes were at highly capitated organizations like Kaiser, right? And so what do we learn from that? Well, we're writing these long notes not to communicate for patient care. We're writing them for compliance and regulatory and other perfunctory reasons, billing, medical legal, CYA, et cetera. And so we got to be careful that we're solving the right problem, not using AI to generate more trash notes, but going back and thinking about how we can rethink what notes should be looking like. In fact, Seema Verma, when she was CMS administrator, started an initiative called Patients Over Paperwork and cited this paper as an example of why they needed to simplify the coding and billing process. And finally, I shared with you the story about the blood clot that I experienced, and we're asking the question now, can computer vision help to prevent DVTs? We think it can, and in fact, it was just announced a little prematurely in the paper that UC San Diego will be adopting AI cameras to help us identify patients at high risk for falls, at high risk for DVTs and other things. In fact, today we use a device called the Leaf that goes under a mattress and helps remind a nurse if a non-ambulatory patient hasn't been turned in 3 hours to help prevent pressure ulcers. If the peer-reviewed studies were done here at Stanford that showed it worked. We pay $250,000 a year for this device that goes under the mattress and reminds the bedside nurse. Could we use cameras in the room to do the same thing? Absolutely. In fact, there's some preliminary data not yet peer-reviewed from a company we're partnering with, and we're excited to be a strategic partner on this moving forward. So I want to wrap up by just acknowledging this health AI paradox, which is that implemented algorithms are rarely researched and researched algorithms are rarely implemented. We've just hired our first chief health AI officer, Dr. Karandeep Singh, and he's working to close this gap. We're focused on developing algorithms and workflows that impact patient care outcomes. And we're trying to do this in a safe, ethical, and trustworthy manner. And we've been sharing some of these experiences with the nation at large. So final thought here, I shared the story about Dr. Frankovich's patient with lupus. And really our goal is to ensure that our healthcare system is learning from every patient at every visit, every time. And if you think about layering AI on top of Cosmos, I think places like Stanford and UC San Diego are going to show us the future of how that's possible. So again, I just want to express tremendous gratitude to all of my friends, colleagues, and particularly mentors that are here. I got to visit with Dr. Butte yesterday, and in fond memory of Chris Dawes, one of my important mentors, Dr. Paul Sherrick up at Seattle, and Lisa Grissom, who came today. So thank you, everybody, for all of your support over the years and enabling my career so I could stand here with you today. And there is a picture from last night there, so we had a good time. Thank you very much, everybody.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.